Hello, I'm Alan Bryce. I'm a medical oncologist here at the Mayo Clinic in Phoenix, Arizona, the chair of the Division of Hematology and Medical Oncology, and a genitourinary medical oncologist almost entirely focused on prostate cancer. I'm here today to talk to you about universal germline screening in prostate cancer and give you the argument against doing this. My principal disclosure here is, in fact, I'm a proponent of genetic testing and I've published in this area and done trials in this space, but I can still examine the counter arguments and have a good faith debate with colleagues who disagree with me. I like this quote from Aristotle when he says, "It's the mark of an educated mind to be able to entertain a thought without accepting it." So the question is, should all men with prostate cancer, whether it be low risk or high risk, undergo germline testing for BRCA1 and 2? So traditionally, we learned this data back when we were in training, that the overall prevalence of BRCA1 and 2 mutations in prostate cancer is only about 1 or 2%. And it's particularly prevalent in high risk populations, particularly Ashkenazi Jews and some Nordic populations and Mediterraneans. And of course, BRCA is more traditionally associated with breast and ovarian cancers and also pancreatic. The narrative started to shift with this data from Pritchard that we saw back in 2015. And it showed that in the metastatic population, the overall rate of carriers of familial cancer predisposition genes is on the order of 12%. And about half those end up being BRCA2 and 1. So ultimately, it's about 6% of metastatic prostate cancer patients being germline carriers of BRCA2 and 1 mutations. And so in 2019, the NCCN came out with this updated guideline saying germline testing should be obtained for any prostate cancer patients with high risk, very high risk regional or metastatic prostate cancer, whereas previously they were only recommending it for young patients or patients with a strong family history or of Ashkenazi descent. We saw this data from Nicolosi back in 2017, which showed that family history based testing based on traditional criteria identifies about 2/3 of carriers, whereas about 1/3 of carriers would be excluded by that criteria. I mean, think of patients who come from small families or perhaps are orphans and don't know their family history. So, why wouldn't we test low and intermediate risk patients? I mean, this is really the heart of the debate here. Well, if we start with the fact that the prevalence is low, only 1 to 2%, and if we then say that family history based screening will identify 2/3 of carriers, then what we end up with is that somewhere around 0.3 to 0.67% of patients will be unidentified by family history and yet be carriers of BRCA2 or 1. And what that means then is that the number needed to screen to find one additional carrier is going to be on the order of 200 to 300 patients. And of course, if we do screen, there is the expense of testing. There's the counseling that the physician has to put in prior to ordering the test in terms of prepping the patient for why are we doing this and what might it mean. And there's the fact that there's a national shortage of genetic counselors. So even if you get a positive test, you may not have a good place to refer the patient to. And of course, we have to follow up on any positive result. We can't just let it go. And then in the high risk or metastatic populations, if we go through the same calculation and we say that 6% of patients will be carriers and family history screening identifies maybe 2/3, then you end up with about 2% of the total patient population who would be unidentified carriers if we relied on family history alone. And yet, in this population, we also have to consider that most patients should be getting somatic testing as well because PARP inhibitors are now approved. And somatic testing, whether by tissue biopsy or cell free DNA, would also detect those patients with germline mutations. So that means that family history based screening plus somatic testing would leave very few patients, if any at all, that would be undetected carriers of BRCA1 and 2 mutations. So responsible resource allocation would argue against universal testing in that setting. So in summary, the importance of genetic predisposition of the patient and his family is not in question. We all agree about that. The question is the best approach to testing. Family history still captures most germline carriers of BRCA2 and 1 mutations, but the potential financial and psychological impact to patients and the resource constraints of the medical system are meaningful. Universal testing would end up becoming a mandate that can divert resources and attention from more pressing needs. And patient centered collaborative decision making should remain the gold standard for testing. Thank you.